Hi, my name is Madison Sheets, and this is my in-service. The people that are attending are here. Y'all can introduce yourselves.
Hi, I'm Sana. I'm Grace Wynn. I'm Ashlyn.
Hello, I'm Morgan McCoy.
I'm John.
Thank y'all for coming today. So my in-service presentation today is on a drug called tolvaptan. The point or objective of the in-service is it worth the salt? So is it worth the drug, having this on formulary at institutional hospitals or any kind of institutional setting in general? So a little bit of background on the drug first. Its generic name is tolvaptan, but there are two brand names of it. They're Genarc and Samska. So Genarc is specifically indicated for autosomal dominant polycystic kidney disease, and Samska is exclusively used for hyponatremic patients and disease states that come from that, so SIADH. Genarc has a black box warning attached to it. This is because it's got more of the drug in it. It's got a higher dose. It comes in 60 milligram tablets, and it's extremely hepatotoxic. So that's why there is a black box warning attached to it. It's also highly restricted through a REMS program. So that's a little bit about that drug, but we're going to focus more today on Samska, which is the lower dose of that. It comes in 15 milligram tablets and 30 milligram tablets. It's indicated for SIADH and heart failure patients, and its significant adverse effect that most people worry about is extreme thirst. So not as bad, even though you do still have to watch out for your liver function during the time that you're taking it. So like I said, there are some specific indications that have to do with hyponatremia. What is indicated for the drug specifically is euvolemic and hypervolemic hyponatremia, which is defined as less than 125 milliequivalents, or less marked, so higher than 125, but if the patient is symptomatic with hyponatremia. Also patients who have resisted correction with fluid restriction, and if these patients have heart failure and SIADH. It is not for underlying kidney disease, liver disease, anuria, hypovolemic hyponatremia, ADPKD, because that's what the other drug is for, and it has an interaction with CYP3A inhibitors. A little bit on the mechanism of action of this drug, why it gained its popularity. It's an orally active, selective V2 receptor antagonist, so it blocks vasopressin and ADH. In the slides that I've provided, there's a little kind of chart that shows its mechanism and where it blocks that vasopressin. This aquaretic activity in the distal nephron induces excretion of electrolyte-free water without changing the total level of electrolyte excretion. So in other words, it retains the sodium, so it keeps sodium in your body and excretes the water that needs to be that's being retained that needs to be let out. So also a little bit about SIADH. This is a pretty common disease state that comes about with hyponatremia. They kind of go hand in hand sometimes depending on what the patient is predisposed with. According to our DePiro pharmacotherapy textbook, patients diagnosed with SIADH are most likely going to be empirically treated with 3% normal saline. This is because there's a higher sodium content in this, obviously, and so that's going to replace some of that sodium that's being let out from the patient. And when these patients have a urine osmolality of greater than 300 milliosmoles, that's normally paired with an IV loop diuretic, such as furosemide, every 6 hours. So the studies that go along with tolvaptan that really gained its popularity in the world are the SALT trials and the Everest outcome trials. So SALT trials is SALT 1 and 2. It was multiple trials that were done over the course of about 4 years. These were important because they showed that compared to placebo, tolvaptan did really well in correcting patient sodium levels at a pretty fast rate. So as opposed to placebo, they raised sodium levels about 5 or 6 more milliequivalents over a 30-day period. The thing about this trial, though, kind of the caveat with that is that after patients were discontinued, after the 30-day trial period, there was a 7-day follow-up where they also looked at their sodium levels, and those sodium levels had plummeted back down to almost where they were originally. So we'll get to that in a second, but that's something to note for now. The Everest outcome trials, those were specifically analyzed the effects of tolvaptan in acute decompensated heart failure with signs and symptoms of volume overload. With this trial, they did not find any significant there wasn't anything about heart failure that made this drug more effective than any other drug. So it kind of proved that tolvaptan, when it's initiated for acute treatment of patients that are hospitalized with heart failure, that had no effect on their mortality or morbidity. But it did, again, increase those sodium levels pretty fast for short-term use. So some things to consider so far is that this is an effective drug for raising sodium levels. Its side effect profile is not high risk, but that doesn't mean that this is a benign drug. And its effects are pretty short-term. So outpatient use is not encouraged. And it's a drug that we see those rapid correction levels, but you also have to follow it with something because those sodium levels are going to go right back down as soon as you discontinue the drug. So also, along with that, cost is also what deters its use in many institutional settings. So we're kind of going to go into the cost benefit now. And this is something that a lot of nephrologists and physicians are considering in hospital settings. A lot of people in P&T meetings have kind of had this new controversy going on with this drug because as it does work very well, it is very expensive. And some patients don't want to be stuck with hundreds of dollars on their medical bill from the hospital when they leave the hospital with semi-corrected sodium levels that are just going back down after they leave, and they need some sort of outpatient therapy that's not this drug. So I gathered some information from McKesson wholesalers. So for sodium chloride, which is what's most generally given to patients, that 3% NaCl in a 500 milliliter bag runs around $2.12 to kind of put it in perspective. 0.9% saline or normal saline is $1.31. Those loop diuretics that sometimes go along with that are either 4 cents for a 40 milligram tablet, 63 cents for 20 milligrams IV, or 67 cents for 40 milligrams IV. There is another drug on the market called demeclocycline. This has been given in a lot of institutions for hyponatremic patients. It's not a mainstay therapy by any means, and it's not really introduced in any of our textbooks, but it's something that can be used. And so this drug is around $4.41 per 150 milligram tab. And you normally give 1 tab a day for about 3 to 4 days until that sodium is corrected. But tolvaptan, when that is given, it costs about $450 per tablet per day given to these patients. So the price difference is huge, and that's definitely something to consider when deciding whether to put this drug on formulary. So in conclusion, Samska can be an effective drug. There are specific indications for this drug, and nephrologists, other physicians, pharmacists, and healthcare professionals helping the patient do need to weigh this cost versus benefit. And cost to the hospital and cost to the patient should be considered before the drug is given. So just kind of some food for thought, and maybe something to think about as we all go into our profession and maybe enter an institutional setting one day. My references are also given on here for all those trials, and that is all I have for y'all. So what questions do you have for me?
Are there any current alternatives to tolvaptan or 3% saline?
Besides that demeclocycline, there's not a lot. There is something kind of controversial on the market right now. It's called urea. The brand is Urea NA. and it's a biologic. It's not a drug necessarily, so it's not FDA approved, but it is being given pretty widely in Europe, and it's working very well, and it's being given to patients with SIADH and who are hyponatremic, so in all settings, and it's a very cheap method of getting your sodium levels to raise pretty fast. So kind of just fun fact, but besides those, there's nothing else FDA approved on the market.
Okay, so what makes you want to talk about this drug versus other drugs available?
This drug is really interesting to me because it's been pretty praised in the last couple years by nephrologists just because it does give you those results that you want from a doctor's point of view. But a lot of hospitals are being wary about putting it on formulary because it is costing them so much money. And those doctors don't understand just how much they're spending with one dose of the drug.
So, my question was, when is it most encouraged to use tolvaptan over the other drugs that are available?
Tolvaptan, I feel like, is most encouraged in settings of like very acute hyponatremia, and then also for patients who not only need it because they meet that threshold of below 125 sodium levels, but are also having some like adverse effects with that of like seizures or something else is going on, and those sodium levels are kind of scary low, and you need a fast reversal that you know is pretty tried and true.
Okay, thank you.
I have a question for you. Where did you find the resources to see what other hospitals were doing with this drug?
Okay, so this is something that a preceptor of mine kind of helped predispose me to. There's like online forums that is through ACCP that you can read kind of what other hospitals are discussing about certain drugs. And so she let me go through and see all the questions that these other hospital pharmacists and physicians have been asking and kind of their discussion and their like points of whether they want to have this in their institution or not. So that's kind of where I gathered that from.
Okay. So since Stemska is not currently preferred in hospital, is the other brand also not commonly used?
Genarc is not commonly used, but it is on formulary for a lot of hospitals just because it has that very specific indication. So no, it's not commonly used, but yes, it's on formulary at more institutional settings than Samska is currently. Is that all?
Yeah.
Okay, thank you so much for coming.
All right.